All right, well, hello again and welcome everyone. I have just a few minutes after 2:30. There are still a few folks popping on, but we will go ahead and get started. So welcome everyone to our early childhood learning community. My name is Lauren Rabinowitz, and myself and Neil Horan, we are with the TA Network. Neil and I work at the Georgetown University Center for Child and Human Development, and we are really happy to be part of the TA Network as those who focus on early childhood. So I hope some of you have been with us before on past learning communities, but for those that have not, I will just briefly review the logistics of how we go about this next bit of time together. We are lucky enough to today have a wonderful presenter, Dr. Megan Sullivan. I'll give her introduction in just a moment, and we're going to have her speak, and she's going to tell us about her system of care project in the District of Columbia. And we will keep lines muted during that time. If you have any questions at all, please feel free to put them in the chat, and Megan will get to them as she goes, or depending on the length of the question, she might wait till the end. And then we will open up the lines at the end. If anyone wants to start some dialogue, we'd be really happy for that. So this is an opportunity for you all to learn not only from our great presenter, but also learn from each other. So we encourage as much conversation as you all would like. I also want to let everyone know there's going to be a survey at the end from the TA Network. So please remember to, it'll pop up automatically when we end. So please don't disappear too quickly so we can get that survey. We make changes to this learning community based on your feedback. And thank you so much to those of you who have been writing into the chat. It's really exciting to see that we have folks from all over the country from a lot of different types of programs. So welcome, everyone. So right now, I am going to introduce our speaker. So Megan Sullivan is the project director for the DC Social, Emotional, and Early Development Project, known as DC SEED, and that is housed at the DC Department of Behavioral Health. Prior to working on the DC SEED project, Dr. Sullivan spent over 10 years working with several Department of Behavioral Health prevention, early intervention, and treatment programs focusing on children. Specifically, Dr. Sullivan provided direct service within the Department of Behavioral Health School Mental Health Program and was the program evaluator for that program. She was also the evaluator for something called Primary Project and Healthy Futures, which was an infant and early childhood mental health consultation program, which is actually where Megan and I first met many years ago when I did a small evaluation of Healthy Futures for my thesis in graduate school. So it's always fun when paths cross again a little later down the line. So I'm going to pass it over to Megan, and thank you so much for sharing some of your expertise with us today.
Thanks so much, Lauren. Welcome, everybody, and good afternoon. Thanks for taking the time out of your busy day to listen to this. I'm going to go ahead and get started, but please feel free to either write your questions in or we can also discuss them at the end. So I'm just going to leave this up for a few minutes. You guys can read this. Okay. So as Lauren mentioned, we have a couple of objectives today. And the first one talks about providing a brief overview of DC Social, Emotional, and Early Development Project, which what we often call as DCC, because it's a lot of words. The second objective is explore the comprehensive approach of the project, including prevention, early intervention, and treatment services, and discuss lessons learned within the DCC project. So in fiscal year 17, the Department of Behavioral Health, or DBH, was awarded this grant, System of Care Expansion Grant, for 4 years. And really the goal of the grant was to support the expansion and implementation of early childhood specific evidence-based and promising practices. And the focus of the grant is to address the unmet behavioral health needs of young children birth to 6 years old who are at risk for or have been diagnosed with serious emotional disturbance and their families. We're currently in year 2, and really just to give you some background, this grant and the application was really built upon a program called PEACE, which is an acronym for Parent-Infant Early Childhood Enhancement Program here at DBH. They're a program who provides treatment services for kids 8 years and younger. And so we have been providing some treatment services in the district through this program, but it was really seen that there needed to be a larger capacity for early childhood. And so that's one of the reasons why a group of individuals got together and wrote this grant. In addition to the message that was received that there needed to be more treatment options in the district for children 0 to 6 who had serious emotional disturbances, there was also a few other messages that really was coming strong through family involvement as well as some of our other community stakeholders. And what those messages really were is that there was a need for an early childhood system of care focusing on all levels of care. So again, obviously we needed more treatment services, but there was also a strong push for prevention and early intervention services for this age group. And then in addition, many agencies, programs, and grants provided services to young children and families, but it was noted that sometimes these services and supports were not well integrated. And so really lots of programs and government agencies that were working in silos. So again, these messages came through strongly, and what a group of individuals at DBH did was put together a grant application for a system of care for young children. So I don't want to spend too much time on this slide, but really also in addition, looking at kind of the public health model in this triangle that I'm sure many of you are aware of, the thought of expanding our treatment services, while important, if you look at the top or tier 3 of it, it really only shows that a small percentage of children would be receiving treatment services. And the strong message through the city was that other prevention and early intervention services would be helpful for early childhood. So again, we wanted it to be a well-rounded model that looked at prevention, early intervention, and treatment. So to talk to you a little bit about our specific grant activities, just to kind of give you a broader sense of DC SEED, I included this slide, and really I just want to briefly kind of talk about it. Some of our major grant activities, the first one, as I mentioned earlier, was to increase our treatment capacity in the city. So what we did was we went ahead and provided, we contracted with 3 sub-grantees to provide additional treatment services for young children. As I mentioned earlier, prior to the System of Care grant, we only had a few agencies that were providing treatment services for early childhood. So as I mentioned, the PEACE program was providing treatment services, and then we also had a provider, Mary Center, who was providing early childhood services. They were at their capacity, and so what we did was we provided them additional services through a sub-grant so that they could increase their capacity. They're actually a Spanish-speaking provider within DC, and so it's really important for us to improve their capacity. We also wanted to contract with Community Connections and Foundations for Home and Community, which are 2 other community service agencies within DC. So these 3 providers were all child providers previously. However, Community Connections and Foundations for Home and Community, early childhood is new for them, and so they provided services for children 6 years and older. So they are now providing services all the way down from 0 all the way up into adolescence. And actually, Community Connections is an adult provider as well. So we increased the number of providers within the city, Another grant activity is enhancing existing services. So we have some services such as community-based interventions within our city, as well as high-fidelity wraparound. We are in the process of integrating those services for our early childhood population. So what we're doing is right now community-based services or interventions start at 6. We're working with our policies and regulations to move those age limits down. So if those services are needed, our providers can provide them. In addition to that, we've incorporated family peer specialists into each of our providers. So these 3 community service agencies, which we mentioned, have also hired family peer specialists, and we're helping, those individuals are helping our early childhood families navigate the system. In addition to those activities, we also are doing quite a bit of early childhood training. Our providers will be trained in 3 evidence-based trainings. We'll talk more about these a little bit later on, but as you can see here, child-parent psychotherapy, parent-child interaction therapy, and strengthening families coping resources. And so our providers will be getting 3 evidence-based programs. However, the grant also has a strong emphasis on early childhood training and really city-wide outreach. So again, it's not just providing the skills for individuals who are providing treatment, but also individuals who may be touching children 0 to 6 years old, so in a more prevention or early intervention capacity. Another one of our grant activities is centralized intake. We are working with another government agency, the Department of Health, to try to establish a single point of entry for referral and linkage. Some of the feedback that we've heard previously is that access and actually getting linked are very challenging, not just in the District of Columbia, but within our region. And so we're trying to make it easier for our children and families to get connected to services. There's also an early childhood mental health consultation piece to our grant. As you can see on the slide, within the grant, we said we would ensure that 100% of child development centers, which are daycare centers, in the district have access to early childhood mental health phone consultation by 2020. So this is something new. I think previously, as Lauren mentioned, Healthy Futures, we do have early childhood mental health consultation within the city and here within the Department of Behavioral Health. However, this phone consultation is a new component, and so this is something that we will be kind of piloting and rolling out in the near future. And then the last component is obviously there's a huge evaluation component, and we partner with Georgetown for that. So again, these are kind of the highlights of the grant activities. I didn't want to give you too much detail, but at the same time I wanted to give you enough information so that you at least had a sense of kind of the system of care that we're trying to create here in the district. So prevention and early intervention services. As I mentioned earlier, there is a strong early childhood training component to this grant and really trying to train across all disciplines. So really looking at individuals, any individual who might be touching a child and or family 0 to 6 years old. So what we've already done is trained on early childhood, focusing on development and the impact of adverse child experiences. And again, we didn't just train clinicians, we invited lots of different types of people to this. We staff, so directors, teachers, aides, at child development centers, schools, lots of different capacities. Some nurses who have experience working with this population came as well as our family peer specialists were part of this. We also trained on the DC 0 to 5 diagnostic classification of mental health and developmental disorders of infancy and early childhood. Very well attended training, and I know some of you, I think you guys last month had a webinar on this. And so again, I think for us, we really wanted to train our folks on this model so that we could start having them use this clinically and assess children using a tool that is appropriate for this age group. In addition to these that we have listed here, we are we're in the process of trying to create an early childhood kind of 101 so that we can have this training across all disciplines and then have it at more than quarterly, probably at least 6 times a year, so that again, we can continue to train individuals across disciplines as frequently as needed. In addition to kind of our training piece, we've also highlighted some of our screening processes. For ASQ3, for Ages and Stages Questionnaire 3, and the Ages and Stages Social Emotional, we're really trying to make sure that individuals across the sectors have access to this, are trained in screening, and are screening appropriately so that any children who need additional services can be referred to the appropriate resources. So we're really trying to provide support in child development centers as well as schools, as well as all the children that are coming in for treatment services. Again, in addition to screening the young children, we're making sure that our children who are coming into treatment services, their parent or caregiver, is being screened very quickly using the PHQ-4, which is the Patient Health Questionnaire 4. And we'll talk a little bit more about this in a few slides, but really we're just asking 2 questions about anxiety and 2 questions about depression. And we're really trying to get a little bit of information, and if there's concerns, then having that clinician provide resources and try and link them to services. Our early childhood mental health consultation piece, again, I mentioned, I think on an earlier slide, that within the grant, our deliverable is that we will ensure that 100% of our child development centers, which is over 380 or so, have access to phone consultation. Again, this is a new model for us, for the district, and it's something that we are we haven't yet rolled out, but are working very diligently to take those steps. While it's important and we will meet this need to provide the phone consultation, it's also very important to our team that we provide the other areas of consultation as well. So as you can see here, we bulleted some other things that we're providing: outreach and education to our child development centers, community-wide social, emotional, behavioral health training, on-site child development training and support, and then the last is obviously for those kids and for those children and families who need a linkage to treatment, and help with the child development centers integrating any child who has an SED diagnosis into their classroom and making those transitions as easy as possible. We are working very closely with our OSSI, which is our state education system, and working with how can we work hand in hand and provide comprehensive services and make sure that we're collaborating and that we're not duplicating. So just to speak a little bit more, this is kind of the same thing I was just talking about, but really in a picture or a diagram form. And you can see that, again, kind of mirroring the public health model, again, within the grant, obviously providing the phone consultation, most likely that phone consultation will be very child-specific or challenging behaviors. So we think most of those calls will be for children kind of at the top end of the pyramid, at the point, and trying to link them to treatment services. However, because we have this strong belief in prevention and early intervention, we think that it's important to include all aspects of this. And so just to give you a little bit of glimpse, we recently did an annual scan of our child development centers to assess kind of what services do they have, what services do they need. As many of you probably do in your own states, we have quite a few of resources. But what we find is that there's lots of centers that have an abundance of resources, and then there's a lot of centers that have very little resource. And so we were trying to figure out how do we best assess what the needs are, how do we best assess so that we can help provide services in the best way. So I just wanted to share a little bit of our first scan and kind of the information that we got back. I did mention that we have about 380 or so, 82 child development centers in the district. And so what we did was we sent a survey to them. And as you guys know, sometimes surveys, you don't get the best response rate. But we were pretty pleased. We got 97 back, which is about a quarter of the group. And some of the very interesting information. I'll just give you kind of a snippet because obviously we don't have a lot of time to talk about it. But we were curious about kind of what kind, just getting the demographics of their center, but also looking at what supports do they have, what supports do they need. We're also very interested in looking at suspension and expulsion rates, as well as what resources would be helpful if we could implement some services, because DCC has one full-time early childhood mental health consultant who could provide some services. And so what we found was, and we also asked about screening. What we found was that about 16 centers or directors indicated that they suspended at least one child in the past year. 12 reported that they had expelled at least one child. Almost a third of the centers reported that they weren't screening. And again, there are quite a few supports within the city for screening. So we found that interesting. And then, somewhat not surprising, the majority said that they could benefit from helping with coaching on challenging behaviors, in-service trainings or workshops around social and emotional wellness, early childhood milestones, and then a big portion also talked about child-specific support. So again, one of the reasons why I wanted to share this with you is, again, I think it speaks to there's a wide range of services that the child development directors are really reporting that they need. Yes, they need help with their most severe kids who might be exhibiting, dangerous behavior or biting, but they're also reporting that they need a lot of support with their staff in professional development, as well as in screening. And so I think, again, this scan just kind of helped highlight that there's areas of need on all levels of the continuum, just not in treatment. So again, as I mentioned, the System of Care grant, again, the main focus was to really increase the capacity of treatment services. As I mentioned earlier, this specific grant, we have created sub-grants with 3 of our community providers. We're training them in evidence-based programs. Last year and continuing into this year, we trained our clinicians and supervisors in child-parent psychotherapy. This current year, in year 2, we're training on parent-child interaction therapy, as well as strengthening families' coping resources. So you guys probably know, since this is an early childhood collaborative and learning community, you probably know at least some of these evidence-based programs, but I just included this slide to let you know that, just to give you some background information. So child-parent psychotherapy is an intervention model for children who are experiencing traumatic events and experience mental health, attachment, and/or behavior problems. And the goal is really to strengthen the caregiver-child relationship and help restore sense of safety, attachment, and appropriate affect. As I mentioned, our clinicians are currently in this learning collaborative. They have just finished, I think, last week or 2 weeks ago, the second learning session. There's 3 learning sessions within it, and so they are implementing this evidence-based practice. The second one that we're getting ready to schedule right now is CCIT. It's an intervention model for children experiencing emotional and behavioral difficulties. And the emphasis is on improving the quality of parent-child relationship and changing parent-child interaction patterns. This is a coaching model. As you guys probably know, this is the one where they have the bug in the ear, the parent and the therapist is coaching, the clinician is coaching the parent while they're playing with the child. And the last model that we will be implementing on is strengthening family coping resources. And this is actually a group model for families. And again, it's for families living in traumatic contexts. And the goal is to reduce symptoms of trauma-related disorders and increase coping resources. So those are a little bit of the 3 evidence-based practices that we're using. I will also say, too, that if a family presents to a clinic and they would like treatment services and one either doesn't want to be in an evidence-based program or they don't fit, so for example, like right now, in order to be in child-parent psychotherapy, the child has to have had a traumatic experience, and so obviously our providers will still provide treatment services. And it's just, they don't have to fit exactly into one of these 3 evidence-based programs. We would ideally like them to receive one of them, but again, for some reason, we're not going to turn a family away because they don't fit into one of the programs or they choose to not be part of one of them.
Hey, Megan, we had a quick question about CPP. I don't know if you're going to get to this later, but Amy was wondering just about how many clinicians you were training, and then an important question about turnover.
Okay, great question. So we initially were trying to train 2 clinicians per provider, and what we did was we actually increased it with the concern of turnover. So I'm trying to count in my head, sorry. We have about 4 or 5 at each provider. So we have about 15 that are currently trying to be rostered. The unique, as you guys probably are aware, with CPP, the supervisors also carry cases at the same time as the clinicians are. And so the difference is that the supervisors have to carry 2 cases while the clinicians carry 4. And sorry, what was the second part of, turnover. So thankfully, I'm a little scared to say this, but thankfully we have not had any turnover yet. One of the things that we hope is helping is that in DC, actually prior to me coming on board, they really worked hard for a separate CPP reimbursement code. So the providers are receiving a higher rate for when they're providing CPP as compared to other treatments. So it doesn't necessarily help retention, but I think it's for the providers, it's helping with a little bit of the kind of the additional things that these clinicians need to do. So it's not just the trainings that they need to attend, but it's also consultation calls. So supervisors are on calls 3 out of 4 weeks a month, and the clinicians are on consultation calls twice a month, as well as their supervision. So again, it's a way that DBH has tried to not really incentivize, but try and show that implementing an evidence-based program like CPP, putting some strength behind that. Did I answer the question? Was there another part to that, Lauren?
That was it for that first question, but Janice had a follow-up. She was wondering if the rate includes fidelity monitoring.
We do fidelity monitoring, but again, I think when they go to bill and they just select that it was a CPP session. So yes, we do fidelity here, but that's part of our CPP consultation learning collaborative. Did that answer it?
Janice, did that, let's see, she's typing in. Great.
Okay. So now I'm going to talk a little bit about successes. So this has been strengthening the system of care for young children and families within the District of Columbia. We have definitely had an increase of collaboration. We have many government agencies, as I mentioned earlier, working with young children or early childhood population. And I think that within our system of care management and implementation team meetings, groups of individuals kind of come together in one place and have a shared drive, and we make sure that we're all working together. And I think that has really helped make sure that we're not being duplicative, or making sure that we're working collaboratively. And then also we have about 5 or 6 different work groups that meet pretty regularly to work on some of these more challenging things. So social marketing, making sure that our services and child development centers are on par with where we think they should be. Also, I think another big one that is true to kind of dear to my heart is financial planning and sustainability. One of the strong messages that's come from family groups and some of our other, other agencies that we work with is that lots of times we do all this great work, and then when the grant money runs out, unfortunately the children and families are the ones who suffer, because those programs and services sometimes also disappear when the grant money disappears. And so I think it is it is one of my missions that once this grant is over, that some of the services that have been beneficial for our children and families can continue to work. And so I think, again, it's important that different groups of people to get together and talk about the sustainability, and also how are you, to be realistic, how are you going to maintain these moving forward? And so some of the work has been done, like with the different rates for CPP, but obviously there's much more work that needs to be done in that area. So also, I think that we really, this second bullet is old. I think we've started providing services for somewhere in the 30s probably now, providing treatment service for young children and families. And 16 of these at the time were receiving CPP services. So again, it doesn't seem like a lot, but when you think about, we've only really started in September with opening CPP cases. And so when you look at the fact that you're working with a young population, and we've just brought on 2 providers that are new to early childhood services, and you add a very extensive intervention like CPP, I think we're kind of moving along. I think what we need to kind of focus and highlight on is how do we retain these children and families and therapists in the treatment. So it'll be interesting to see in a few months how many were we able to retain, hopefully the majority of them, as well as how do we continue to increase. One of our providers is actually right at capacity right now for CPP, and so while that's a good thing, it also is concerning because we want to be able to have room if there's more children that need it. Another success is that we're screening parents and caregivers of children with this PHQ-4 for depression and or anxiety, and I think the next slide talks more specifically about it. But really what we found is of the 28 individuals who were in treatment, their caregivers, 7 of them screened positive, which is 25%, for depression and anxiety. Again, you need to remember that it's only 4 questions, but they're endorsing very high levels. And then when you're only looking at anxiety, 9 or 32% of the caregivers reported symptoms of anxiety, and 8 or 29 caregivers reported depression. So again, and I'm pretty sure that these are, very similar to kind of what the research is showing, but what we're looking at in our population is just briefly screening our caregivers. We see that almost a quarter of them are either experiencing depression and or anxiety. And so what I'll tell you a little bit more about it, but what we're doing is providing resources and trying to link the caregivers. Because as you guys know, when you're working with children, you're also working with families. And it's important to make sure that the caregiver's mental health is addressed if necessary. So this is just, again, very brief of what the questions they're asking. And so what we've done is we've actually included this into our NOM survey. And so when the clinician is working with the parent or caregiver to complete the questions, and so it's just a good way to kind of quickly screen while you already have the caregiver's attention. And I will say, it's not on here, but something that our evaluation team has been able to do is they made our knobs electronic, and what happens is when the caregivers score in an elevated or a positive range, what ends up happening is the clinician immediately knows on their screen, and it goes to a link where they can click on it, and it provides the parent with some resources. So one of the handouts is a list of adult resources in our community so that they could have that. Obviously, the clinician can help that individual connect right then if they want to, or they can hand them the resource list and the parent can go, or caregiver can go home and make an appointment if necessary. Also, it provides handouts on things like stress management. Talks about ways to what anxiety is, how to decrease those, as well as depression. So again, this is something that's really been helpful for our clinicians to be able to, one, quickly assess parents and caregivers, as well as give resources if needed. So those are a few of our successes. Our lessons learned, again, I can't say the first one, and I know all of you guys know this, systematic buy-in and collaboration is imperative. I think that if you continue to work in silos, it's really hard to get work done, and it's really hard to get be as effective and efficient for the children and families. So I think that's essential. Also, comprehensive early childhood training is essential. So what we learned is, and you guys all know this, that just because you were trained as a child clinician doesn't mean that you have the knowledge to do early childhood or work with young children. And so we've been trying to, along the way, really kind of insert early childhood trainings and consultations so that we can provide the necessary skill set. Again, I know I've mentioned this a couple times, but I think it's really a lesson learned for us. 2 of our 3 providers were not early childhood providers prior to this grant, and so trying to get them the knowledge that they need has been an ongoing kind of exercise. And as you can see here, ongoing or booster sessions is a good addition. Also, kind of going back to CPP, I think the ongoing consultation, but also just constant support is necessary. It's a challenging evidence-based program, and so I think any way you can support the clinicians helps retain them. The next one I spoke to, the process from shifting from being a child provider to an early childhood provider takes time, support, and training. Another lesson learned was within our grant, we initially started with child-parent psychotherapy because, one, it was the longest kind of learning collaborative, but 2, we thought if we waited till year 2 to do PCIT training, our providers could spend year 1 kind of getting their rooms for PCIT up and running, so getting their two-way mirrors, getting their audio equipment, getting all of those things set, and doing any kind of build-out if they needed it. I think in hindsight, it might have been a little bit easier for our clinicians if we would have rolled out PCIT first. It's more structured, it's more manualized. I think it would have given them some more concrete concepts. And then we could have kind of rolled into CPP. Again, just I think something to think about is kind of how you roll out the evidence-based programs. I also think we're rolling out 2 in 1 year, and so I think we might have some lessons learned from that at the end of this year as well, kind of making sure that things are spaced accordingly. Another kind of lessons learned is ensuring referrals were obtained from a variety of sources. So, of course, when we put out our sub-grants, we asked individuals to identify how they would get, referrals, or how they expected to get early childhood referrals into their system that didn't have them in the past. And so I think, of course, they all had very good responses, but I think when it came down to it, it was a little bit harder than they expected. So again, I think some of our suggestions is to make sure that you're trying to obtain them from a variety of different places. A lot of our agencies expected to get referrals from the families that they're already working with. So for example, some of our providers already do trauma-informed care, and so they thought, well, this family has young children and we haven't been able to use this other model, so this model we'll be able to use with them. And they thought that there would be an easy referral pattern. So some of that has happened, but to be honest, I think that most of our referrals have really come from the agencies going out and doing outreach at various places where there are 0 to 6. The other piece that's been hard too is that we started obviously with CPP, which requires the child and family to have a traumatic experience, and so you've already kind of limited the number of kids that you might be, your pool. And then another lesson learned was establishing a learning collaborative for evidence-based programs. As you guys know, I'm preaching to the choir, but I think it's extremely challenging to implement evidence-based programs, especially programs that are long in duration, in clinics. And so I think when you do that, you need to provide a lot of support in TA to help maintain those programs. And especially when the agencies are implementing more than one evidence-based program. As you guys know, it's a lot of time and effort to implement, and so I think that support really needs to be there. And I think the support needs to be in different ways. So sometimes it's face-to-face, sometimes it's booster sessions, sometimes there's consultation calls. Again, I think that, and you need to regularly get feedback from them on what are they missing and how can we be supportive. Another thing that we've really had to do a lot of work around is partnering with our providers to manage the clinic requirements. So, as you guys know, in order to keep their lights on and their doors open, they need to be able to bill and get the revenue for that so that they can obviously pay their bills and continue to provide services. But with that being said, obviously, to implement an evidence-based program, there's lots of activities, and even being part of this grant, there's lots of activities that are not billable. So, the 7 days of training that's required, all of the consultation calls. Again, so really having an open dialogue about that and at the beginning, but then also talk about ways, how can we help support you, but at the same time, we obviously understand that you need billable hours. And then the last, I think the last lesson learned that I have written down is really about being part of SAMHSA grants is great, and I think that there's lots of great data that they collect that's very helpful, but I think the feedback from our clinicians and some of our providers is that the amount of data is just so intensive between what SAMHSA needs, between what our evaluation team needs, what the government needs. And so we've really worked as a team with our evaluation partners, but also with our providers on trying to lessen the burden as much as possible. How do we get it to so it's manageable? Everybody gets what they need, but at the same time, the providers can see the utility in it, because we don't want them just to complete the data to complete the data. We want them to use it clinically, and we want to also make sure that we're listening to their feedback. And what I want to share is that the piece around the being able to make our NOMs electronic was direct feedback from our providers. Our providers complained that it was burdensome, it took too long, and so our evaluators were able to lessen some of that and then also make some adjustments. So I think that's important. I think now we have our providers feel like they've been heard, and as a result, they're doing a great job of getting in the necessary data, and therefore we'll be able to share with them on a regular basis kind of where we're at, how are the programs working, do we need to make adjustments, and how do we continue to move forward. So just a little bit about next steps. Obviously, I mentioned that we're continuing to train on CBP and implement our two additional evidence-based programs, and continuing to create and strengthen our early childhood community of practice. It's always a work in progress. I think that, you know, we continue to try and collaborate with all and anybody working with this age group. Excuse me. And with that is obviously our work group and committee meetings. Right now, we're working on providing additional training opportunities. So again, our early childhood 101, but also we've surveyed some of our community stakeholders, as well as just some individuals who are working with 0 to 6-year-olds, and really looked at what some of their training needs are. And so we've come up with some additional areas. There's a lot around kind of challenging behavior and crisis work, and how to assess young children. And so we'll be providing some additional training and support around that. Again, like I mentioned before, strengthening our partnerships with the early childhood sector. I didn't speak too much about this, or really at all today, but really fully implementing our social marketing plan. So again, I hope you know, that the message gets out there what DC Seed is, how can we help people marketing that. I think we really want to get to the point, for those of you who are in DC know that there's also a boarding school here in the city that's called DC Seed. So I hope to get to a place where people are like, oh, I know that program, or I know that school, and it's, you know, they're talking about the right one. Either they're talking about the system of care grant, or they're talking about the school, and they're not kind of intertwining them. And then, as I mentioned a while ago, developing and sustaining the sustainability and strategic financial plan. Because that's really, in the end, we want to make sure that the programs and services and supports that we find to be effective within this program, we hope that we're able to maintain those once the funding is gone. So I think that was the last slide. I'm not sure if anybody else has any questions.
I see that a few folks are starting to put a few questions into the chat. Thank you so much. Why don't we open up the lines just in case anyone would prefer to speak. And if that doesn't work, we'll remute, but we are currently unmuted, so if you would like to speak, you can go ahead. Casey was asking if you can go back to the last slide.
Maybe.
And Casey, did you have a question about that specifically, Casey? Just taking some notes. Okay. And Carrie, she had a question about whether or not you have a parent advisory committee, a community parent advisory committee.
So we actually have a position is vacant right now, but we have a family engagement coordinator who will be organizing that. We had one for our previous system of care grant. Yes, it's extremely important, and we work with other parent councils, but currently we don't. We're waiting for that person to come on board so that they can do that. And we're actually trying to hire someone who is a parent, who was a parent or is a parent of someone who has been through our system of care, and specifically early childhood 0 to 6.
Great. Did that answer what you were looking for, Casey? Carrie. That was Carrie. Great. Okay. And Janice, I see that you had a question about, you were wondering if Megan could repeat her takeaways from the survey, and Beth was letting you know that you can download that. So I don't know if you want to quickly repeat that, but also just to make sure everyone sees that the presentation is available for download in the file pod, which is right below the chat.
Sure. So, I mean, I think kind of the main takeaways from it were, I should also mention, too, I don't think I mentioned this, we sent it out to 382 directors, and it was a relatively up-to-date list that we got from our partners, and 52 emails bounced back. So, again, I just want to reiterate that we all know this, but the amount of turnover is enormous. So 97 of the 382 we got back, so it's about 25% of our directors for child development centers. And I should also mention this doesn't include our home-based centers. So there's a lot of home centers in the city as well. And I want to mention that even though while our deliverable within the grant does not mention providing phone consultations to these centers, you know, it is not, we have not forgotten them, and we hope that once we have some lessons learned from working with our child development centers that we will then be able to provide some services in the home-based centers as well. But anyway, kind of a review of the findings were that 16 directors reported that there was at least one suspension. 12 reported that they expelled at least one child in the last year. Almost a third, or 32%, are not screening their children at all. Even with all of the resources in DC, we have an abundance of resources really to train, to provide them with the ASQs if they want them. So I think for us that was a pretty large number. And then kind of just, I think the takeaway for me was really when we gave them a list of options of things that where they thought we might be able to be where we would be the most helpful, they really touched on activities that were all along kind of the continuum. So prevention, early intervention, and treatment. So of course they talked about the need for support and child-specific services. So either referring to a treatment service or, you know, maybe providing child-specific consultation, like regarding a child who's biting or something like that. But then they also really talked about coaching teachers and assistants on working with challenging behaviors. They also talked about providing, I mean, there was a huge, huge number of individuals who talked about needing professional development and service training on early childhood milestones, on social emotional wellness. And so, again, I think kind of the takeaway for my team was that they really do need services kind of at all the levels. And of course, obviously, we want to link those kids who need treatment services and help with those high-end kids so we can reduce suspensions and expulsions, but really try and support all staff and all the families at all different levels. I will also say that, I mean, it makes sense, but another kind of surprising thing that we found is there's been a huge request for self-care professional development. Again, I think it makes sense. You know, working with young children all day is very stressful, very taxing, and so there's been a lot of requests around, can we help with self-care, and how can we provide some professional development across all levels of the centers in regards to that, parents as well.
All right, we actually have several more questions coming in. So Rebecca has 2 questions. So her first was that you had mentioned a central point of intake within the Department of Health. She's wondering how or if this is going to require an integrated data system, a new data system.
So we're actually going to do, they're actually implementing Help Me Grow, so that it is a data system. So we will be working with them. Basically, the call will come into their center or, you know, their office. And it's not just for behavioral health. So within Help Me Grow, it could be developmental issue. It could be they're helping try and connect them based on some other, you know, they need a pediatrician or they have struggles in other areas. However, for the behavioral health piece, we have worked with them and are currently continuing to work with them to create profiles within their directory, sorry, I can't think of the word, and so that one, if a behavioral health is the concern, they put it into their system or their database, and basically it goes off of a few things, but based on their address, based on what the presenting problems are, then their care coordinators help to provide that linkage. And the other really great thing is that they have care coordinators who then follow up. So it's not just the linkage. They're making sure and following up with that family that they actually did make their appointment. And if there's any concerns, they then have the ability to contact the point of contact at those agencies to make sure that that family really is engaged. So yes, there's a database. And also too, so for example, if they had a copy of the ASQ, they would then forward that to the referring agency so that family wouldn't have to go through the ASQ again or whatever assessment. So we're trying to, one, streamline access and linkage, but also reduce the redundancy of, you know, the family telling their story 3 or 4 times, as well as completing like an intake or assessments, because we all know that that's barriers. Telling your story one time is enough, so I think we're trying to streamline it. So did that answer her question?
Yeah, well, she can chat in if it did or did not. But you know, along the lines of barriers, she was also wondering, you know, about consent to release information across service providers. She's curious if that was an issue, and if so, how you've overcome that barrier.
So yes, I think it definitely is an issue. I think that with the help that they actually have care coordinators at DOH, they obviously are getting the consent right when the parent calls. And I think they're having the conversation around, we're trying to be the person to help make the system as smooth as possible and to reduce any barriers. And so I think, obviously, it's still the parents, you know, they need the consent in order for them to communicate. But I think in most cases they do, because they understand that that person is trying to be the middle person and help them with reducing kind of some of the barriers.
Great. And there's another $1 million question here from Sally, which is actually similar to a question that I had for you, Megan. She's wondering, how did you ensure shared understanding of system of care values within the Department of Health?
It's a good question. I mean, I think it's a work in process. So really the Department of Health, I mean, I think first it's also, you can't just assume that within, like, I work in the Department of Behavioral Health, we constantly have conversations about that even within our own teams. And I think that it's a constant conversation. I think one of the things that we do is that during our implementation kind of system maintenance and implementation meetings, we're constantly talking about those core components. I will say, too, with our providers, we are constantly trying to reiterate those components because, again, their focus is on billing. And while we understand and then get that, that doesn't always, it doesn't always match with the components of system of care and the core elements. And so I think any opportunity that we can have those discussions, we do. Again, I think you're right, it's the million-dollar question. I don't think there is an easy answer to it. I think one important thing that we've learned is that it's helpful to have other people talk about it. So, like, I could talk about it till I'm blue in the face, but sometimes when you can get a champion from, like, say, a provider, or you get a family member talk about it, that message, they could say the same exact thing as you, but I think it's received differently sometimes. And so we've seen that, for example, using our peers, saying the same message to like an executive director at a provider has been really effective.
Mm-hmm. And would you say something similar? I have sort of the same question, just with a slightly different lens. So I'm so curious and so impressed by the amazing amount of prevention that DC has invested into your system. And I think sometimes that's with system of care, and we talk so much about treatment. Just curious for some of your thoughts on how you all have been successful with that prevention side.
Again, I think it's getting a champion. So I think one, you've got in the beginning, you have to have some data to support it. So I think that it makes sense to a lot of people, but you obviously need money. And so I think sometimes when you can use data to show that it's effective in, for example, like there's a return on investment, or you can show that it's helping to reduce costs, you get people to listen. And I think that's how it started. And then I think, honestly, when you look at families and they're the champions of saying, hey, this program is really effective, it helped keep X, Y, or Z, or it helped me stay out of more expensive treatment services, I think that's what helps kind of be the champion for it moving forward. There's no one thing that has helped. I really think there's, it's just systemic. It doesn't really answer your question, but I think that it's multi-layered. So you can't just focus on the money. You can't just focus on implementing prevention. You've got to get everybody behind it. So families, the communities, the foundations, the government agencies, the education, or the school system.
Yeah, no, I think that's a perfect answer, and I agree with you. It isn't a one. It's not something we can answer in one way, and maybe that's part of the problem. Is I think we're all kind of searching for that. But I really like the way you put that. Do others have questions for Megan while you have her? You can tell she is a wealth of information. You're welcome to speak or put something in the chat. Give folks a moment to think about it, as I think several of you saw that you are able to download these great slides. See, it looks like we might have one more question being typed in. While we wait and see if we have another question, I'm going to again remind that when we finish up in a few moments, there will be a quick transition to the survey. So Carrie was wondering about, as far as sustainability efforts, if the numbers of participants are low, like you had mentioned, sometimes they're low, how is that impacting data collection for grant writing? That's a great question.
It's a great question. I think not only are they low, but then again, the number of actual children and families where we can get like a pre and a 6 months and a 12 months, it's, the ends are going to be very small. I think that one of one of the things that we're doing is that obviously the data is important, but we're also trying to capture information along the way. So whether it's kind of, I think they're calling them learning or maybe talk sessions. So we're trying to get information in focus groups as well. So, I mean, obviously we need the data to support it. I'm scared to say this, but I'm a little surprised at how willing and eager our families are to participate. So that piece is great. It's a good question. I'm not sure exactly what we're going to do if we don't have, we can only report on what we have. I will say that we're a little surprised at how many people were in CPP. I think what we're going to be interested in seeing is how many we can retain. Hopefully it's a good percentage. I also think, though, that the program that I talked about before, PEACE, they've been implementing CPP and PCIC for, I think, 4 or 5 years. And so within the government and in the city, I think there's a lot of support for the programs. They've seen the effect of it, and they see how families have improved. Again, that's not the same to say as in numbers and obviously in papers and things like that. But we're hoping that our numbers continue and we'll be able to see some improvements. And I think too, what we're really, obviously we want to see improvements in the evidence-based programs, but if we don't see improvements, we need to talk about that as well, because I think that has implications for the future.
Yeah, absolutely. And Carrie responded that maybe the success rate or percentage is a good number to utilize in reporting.
Right.
Definitely agree.
Well, and I think,
go ahead.
Again, I'm scared to speak about this right now, but I will say that we're very happy with the retention rate of clinicians right now, and so I think that we need to do some work on really talking about what are the things that we've done to help these clinicians and or supervisors and or providers so that we can continue that. Because again, it's hard. It's hard to retain them. And we've seen it with other evidence-based programs within the district that hasn't been successful. So, I mean, my guess is I think CPP has a strong learning collaborative, so that's one of, obviously, the hypothesis. But I think, we need to look at that more in depth as well.
Yeah, absolutely. So Mary had a question about the preventive activities and resources you provide. Mary, I'm not sure if you wanted something very specific or if you just kind of were wondering overall about the different prevention activities. If you have any thoughts on that, Megan.
Yeah, so I think that within, I'm not sure if she's talking about child development centers, but within the child development centers, we're really, our early childhood mental health consultant is really using resources that, that are out there. So she's making presentations on things like early childhood milestones, stuff on successful, really pulling together resources that already exist, but just trying to support the environment. So all of the early childhood kind of websites, Georgetown has a really good early childhood website as well as all the successful stuff. I think that the thing that's important for her is that she's really trying to hear and build a relationship with the center director and or staff, whoever's reaching out, and trying to hear what their needs are, and then trying to provide some of those prevention or early intervention resources. So it's a wide range of things. It really depends on kind of what the needs are. Within, kind of the prevention of the whole grant, we're really, I think kind of for me, creating this early childhood 101 curriculum is kind of what we're calling it. So really just trying to get down to the nitty-gritty, because I think that there's a lot of individuals out there who work with 0 to 6 who really don't have a good, strong early childhood base. Like, I'll use myself as an example. Like, I was trained as a child psychologist, but I wasn't trained in early childhood. I mean, I can't remember, even any, I'm dating myself, but I can't really remember any content on early childhood. So I think for us, the prevention piece is really trying to get what seems like basic information, but get the opportunity for anybody who's 0 to 6 to get those kind of core competencies for early childhood. So those are a couple of examples. I mean, I think we're doing prevention in a variety of different ways, kind of in different components of the grant.
Absolutely. And Bernie was wondering about, for the centralized intakes, are all potential referral sources using the same screens and assessments?
That's a great question. So I will say we're not there yet, but for DC Seed, we are using the same kind of intake referral process. So they're required to do the same types of things. So like they have to do the same trauma screen. However, like their diagnostic has some leeway depending on their own agency. Going into the centralized intake, that Help Me Grow has their own kind of, I don't necessarily want to say intake, but they collect their own information, and it's the same for everybody. And then they will send it to, for those behavioral health agencies, they will send that information. So hopefully that parent doesn't have to give their story, give their pieces, some of the pieces again, once they get to that agency. So some of the pieces are, I think for DCC providers, it is very specific and it's very driven. One of those pieces is we decided as a team that we thought we needed to be consistent. The other piece is data collection. So obviously, at the end of the day, we want all of our agencies, no matter whom they're getting services from, to have the same data point. So like they're all getting ASQ, ASQSE, they're all doing the same trauma screen, and then obviously depending on which evidence-based treatment, so for everything other than PCIT, we're using the DECA-C. So yes, I think we're trying to be as consistent as possible. Again, that's a work in process, though.
An endless work in progress, and you guys are working hard at it. Janice is wondering about your collaboration with Early Head Start or Head Start programs. Head Start's a little funny in DC.
Yeah. So we do collaborate. I will say that especially so we collaborate greatly with OSSI, and within our child development centers, we have a strong collaboration. With that being said, we're still trying to kind of work on the process and trying to, and I should also include DCPS as our school system. And so those three entities are trying to work together, again, as well as kind of early learning, to make sure we're all on the same page. Part of our hopes in kind of scanning was to try and see where the resources were and to see where there was needs. I still think we're working in that area. As Lauren said, it's a little bit challenging in the district. I think that it's an area where we can improve for sure.
This group is just amazing. You all are asking extremely important and hard questions, like this next one from Mary. She's wondering about Medicaid and whether Medicaid can pay for some of the services for Medicaid-eligible clients.
So it's a great question, and I think something that our financial sustainability work group is looking at. I'm wondering if I'm assuming she's talking about the prevention and early intervention. So definitely.
That's my guess. Feel free to elaborate or speak up, Mary.
Right. Our treatment services are definitely billed through there. So we are, we're working. We actually have a close relationship with our healthcare finance, and so we're working with them, as well as working, I mentioned DC 0 to 5 a little bit, the diagnostic classification system, so we're working a little bit on that because, of course, like, it makes sense to use DC 0 to 5 when you're working with 0 to 5-year-olds, but obviously those codes don't translate into billable codes, at least within the district. And so there is a lot of discussion, and we're trying to work on some of the service potentially. Again, if, an early childhood mental health consultant, if they have the right credentials and background and licensure, could potentially bill for some of their services within the Child Development Center. Again, prevention and early intervention services, not that I'm currently aware of, but it's something that we're very interested in pursuing. So if you're in DC, I would love you to join our work group.
Let's see. I see Mary is typing in, so I don't know if she had a follow-up to that. You all have had fantastic. Megan, you should be really proud of yourself. This is amazing participation from everyone, which I think just speaks to how important this topic is. Okay, Mary, you were saying that particularly interested in consultation in Florida. Yes, I can actually just jump in for a moment and let you know one of the other hats I wear is with the Center of Excellence for Infant and Early Childhood Mental Health Consultation, and we are working really hard in thinking about the financing piece. It is so hard. I don't know if you had anything else specific to the consultation, Megan.
No, but I think that I will say that I feel like there's been some movement on it, you know what I mean? Like, I don't think that it's in the same place that it was years ago.
Yeah, I think you're right. And to me, the reason why, because we're now working so much on understanding the different structure of mental health consultation programs, just like that saying about Medicaid, if you know one Medicaid system, you know one Medicaid system. It's exactly the same thing with mental health consultation. So I think, to me, that's one of the reasons why it is so challenging, so individualized.
Yes.
Other questions? TR has pulled up the survey, which is in the chat, so if everyone can please be sure to click on that. We do still have another few moments, so if anyone had any other questions, comments. Our next learning community is scheduled for May 21st, so just about 2 months from now. You will get the information, as always, in the TA Telegram to register. Let's see if Amy has one other question. Oh, great, Amy. So she's taken lots of notes, and she's very grateful for all the information, and I can definitely speak from the TA network. Megan, we are very happy that you were able to join us today and to give such great information about the work that DC is doing, and not just the nuts and bolts, but really to give such thoughtful information on all the planning and the hard work that's gone on. And I think we all really appreciate how thoughtful you are about the future and how it's not enough to just think about where you've been, but to always be thinking about where you're headed once the grant funding is over. So anyways, everyone, please do take a moment to click on the link to take the survey. Feel free to download the slides. Be in touch with us if you have continued questions, and we will be in touch in just a few months. So thank you all so much. I hope everyone has a wonderful day.